Good afternoon. This is Miss Hillman. I will be recording lecture for chapter 26 in the orange book. It is chapter 27 in the green book. This is labor and delivery, also known as intrapartum. All right. A birthing plan is very important for mothers. If you're working in the OB unit, OB clinic, part of your education with these expectant mothers will be to have a birthing plan. And the sooner they have their birthing plan, they can start planning more about where it's going to be, get a tour of the facility if that's necessary. So we have some options for birth settings. We have the hospital. The hospital has a big advantage. There are medically trained personnel who will assist with the birth. Some hospitals have the birth and the mother's room all as the same room. In this, they will be given a room. They will actually have the birth in that room, and then afterwards, the room is cleaned up, and that will be the room where the mother will stay until they discharge in 1 to 3 days. Other facilities may have the labor in one room and then get transferred to a room for them to stay until they discharge. Also, another option, if there is to be a cesarean section birth, this birth will, of course, occur in an operating room, sterile procedure, and then after the birth, the mother will be taken back to a room and the baby to the nursery, and then the mother will stay in this room until the time of discharge. So again, hospitals do have good advantages because of having medically trained personnel in large areas for families to wait as well. Another option, which I'm really not sure if we have in our area, but it's called a birthing center. These are a standalone center similar to a surgery center, whereas this is a birthing center, and that's what this center does, just births. They're, like I said, not affiliated with a hospital. These would be for low risk births where there are no expected complications, and there has been no complications throughout the pregnancy. These are more like a home setting, in a bedroom potentially. So like I said, a different option maybe in another state, but I'm not aware of any close to the Searcy area. The third is a home birth, and that is intended for low risk with no complications expected as well. If there were to be a complication arise, then the mother would be transported, of course, to an emergency room, a hospital close by, so that the baby could be born there if there was an emergency. These births are often led by a midwife or another professional called a doula. All right, there are two theories about the cause of an onset of labor. One of them is a mechanical theory that explains that once a hollow body organ, meaning the uterus, reaches its full capacity, the baby's fully grown. The baby's been there for 37 to 40 weeks. It will spontaneously contract and empty. Another hollow organ that reaches capacity, we may think about in the body, the bladder with the voiding of the urine, or the stomach when it gets full will, of course, vomit. So the second theory is based on hormonal changes, either the mother's hormones or the baby's hormones, or possibly a combination of both, have started the labor process. Again, let's see, we have hormones. We have oxytocin, which stimulates the contractions. In the hospital, a mother may be given pitocin to speed up the progress. Progesterone, estrogen, and the fetus has fetal cortisol. So, but again, with these theories, they have not been proven. So again, something to kind of think about and ponder. All right, we have some signs of impending labor. The first one, lightning. It's more lay term would be the baby has dropped. The baby does drop into the pelvic cavity. With the dropping, typically the mom can breathe better because the baby's not pushing on that xiphoid process. But the mother may have more frequent urination because now the baby has gotten closer and is annoying the bladder. She may have to frequently go and pee with this as well. A backache. Some mothers do have a backache with birthing process. The bloody show may be the mucus plug, which is the plug over the cervical os, becomes dislodged. And again, like I said, it's kind of a mucousy, bloody plug. So that's another sign of impending labor. Contractions, again, contractions will be monitored. The mother should at home time the contractions, write down how long the contraction lasts, the start time for the contraction, the end time, and carefully monitor this progress so that she's not getting to the hospital hours and hours ahead of time. Sometimes, of course, it's good if the mother is thinking she is in labor to go to the hospital, have it checked out. So I always encourage them to come into the hospital and get it checked out if they're not in true labor, or if the contractions are, several minutes apart. They may tell them to go back home and wait and rest until the contractions are coming, say every 10 minutes or 15 minutes, whatever the physician, the OB doctor goes by. Slight weight loss. Some mothers do lose 1 to 3 pounds within a few days of giving birth. This is another good indication. Effacement. The cervix begins to thin and shorten with the progress of labor. And the rupture of membranes, of course, is the amniotic fluid. The amniotic sac has ruptured and will we know then at that point that we need to be getting this baby delivered within 24 hours. If the mother water breaks in front of someone, they need to make sure they're writing down the time that the water broke, and she needs to get on to the hospital quickly because again, we have a 24-hour window to get this baby born. If the baby does not make its way down, they will potentially do a C-section so they can get that baby out. After 24 hours, the risk of infection goes up and up. So we definitely want to get that baby out so there is no chance of infection. I would encourage you to look at page 819 in the orange book. It is a very similar page in the green book, but it talks about the assessment of the amniotic fluid characteristics. Again, when the fluid breaks, the nurse will want to know, record the time, the color, viscosity, any odor, and amount. And if you, like I said, look over that table 26.4, and in the green book it should be 27.4. Very good table to refer to. All right, moving on. Normal labor. We have a list of false labor and true labor. False labor, the contractions are irregular and erratic, whereas true labor, the contractions last longer and come at shorter intervals. The intervals increasingly get shorter and shorter in between the time of the contractions. They false vary in length, whereas again the true become closer, stronger, and last longer. And also with true labor, getting up and walking usually makes the contraction stronger. False labor, more noticeable in the fundus. True labor usually starts in the low back and travels to the lower abdomen. False labor can typically be stopped with relaxation. Also, mom getting up and walking around, or it's been said taking some Tylenol will also affect a false labor and will make it stop as well. With false labor, there is no effacement, there's no thinning of the membranes, the cervix does not begin dilating, and the baby does not start moving head down into the birth canal. Whereas true labor, the baby does continue to descend into the birth canal. Most of this can be found on table 26.1 or 27.1. Induction of labor. Induction for labor is related to starting the contractions before they actually begin spontaneously or on their own. There's quite a trend with mothers being induced in labor, meaning that they pick a date with their OB doctor based on their due date, and the client will go into the hospital and be hooked up to IV meds and be induced with, typically it's with artificial Pitocin. And this may be close to the due date, or if the mother has gone past the 40 weeks. As again, We talked about the placenta is only good for about 40 weeks. After 40 weeks, the placenta starts to die, and so therefore we've got to be getting that baby out. Augmentation is done after the uterine contractions start on their own, but at some point they're not progressing. The contractions should continue to come faster and last longer up until the point we're giving birth. But for whatever reason, this doesn't happen like that, and so the physician will help speed up the contractions. A lot of times this is also done with IV Pitocin, so that we can have the birth of the baby, and we're very mindful of watching that 24-hour window. Okay, there's some different types of help with the induction and or augmentation. There's amniotomy. That's the actual breaking of the amniotic sac so that the amniotic fluid will come out. That also gives the baby room to start coming down, descending into the birth canal. There's a little side note here if a expecting mother comes to the ER or to the labor and delivery area thinking she's in labor and she feels like her membranes maybe have ruptured already, there is a special tape called nitrazine tape that can be checked to see if this is true amniotic fluid. The nitrazine test paper, when it determines the pH, so when it is touched to the inside thigh, wet area where the fluids may have ruptured, the paper will turn deep purple, and this is indicative that this is true amniotic fluid and that the amniotic membranes have ruptured. Because during this time, especially with new mothers, they may feel like their fluids have ruptured when in essence they may have actually just peed a little on themselves, and that is quite common. Again, remember that baby is down into the birthing canal area. It's dropping lower and lower, putting more pressure on the bladder. So it just makes sense that you want to get that checked out. If you think your water has ruptured, get some clarification on that. Let's see, another way they can augment or get this labor and delivery moving along is apply some prostaglandins to the cervix. On page 829, it talks about the induction and the application of prostaglandin gel on the cervix. They will also be on a monitor. They will have the contraction monitor and the fetal heart monitor on the mother so that they can watch the contractions as they progress and also see the baby's heart rate related to the induction process. Another option to help with the augmentation, nipple stimulation, touching and caressing the nipples by the mother doing so themselves, or if the father's part of the birth, he may be asked to do that. So that, again, stimulating the nipples causes release of the oxytocin so that we can progress and get this labor going and have a baby birth. The last option is IV Pitocin. Nurses are in this area are specially trained how to run the IV Pitocin. They're also are allowed. They're allowed to adjust the rate depending on the strength of the contractions. Again, they're titrated based on the contractions. And we want to monitor that heart rate because we don't want it going too fast as well either. So we monitor the heart rate and the contractions carefully. They also document this. If there's problems, the fetal heart rate's changing, either it's too low or bradycardia, or too high tachycardia, or there's some arrhythmias, or excessive frequency, duration, or pressure during the contractions, they may stop the infusion so that we're not causing harm to the baby. We definitely don't want to cause any harm with that baby. Process of labor, it is the passageway, the pelvis, and the soft tissues, the passenger, the fetus, and then the placenta and the after delivery of the fetus. The powers are the contractions, the position of the mother, whether standing, walking, laying on her side, squatting on her hands and knees, and the psyche is the psychological response. All right. Passageway, the pelvis. Oftentimes they'll do an ultrasound, which is safe for the baby. They'll determine the size of the pelvis, the size of the baby, and the baby's head. Can the baby be safely birthed vaginally? And this can be done at the hospital at the time of delivery. Sometimes physicians may do this the last OB checkup as well, because if the mother has a small pelvis and the baby has a little bit on the larger side of the head, they may go ahead and plan to have a C-section so that mom doesn't have any problems and the baby doesn't either, because we don't want that baby to get stuck. The true pelvis is divided into three segments, the cavity, the inlet, the cavity, and the outlet or mid-pelvis. Like I said, again, they will determine the size. The easiest way is through an ultrasound. That also helps to know if there is more than one baby there as well. That pelvimetry is an evaluation of the size. The MD does that step if it's necessary. This is some ways to look at the pelvis. Mothers can have a couple of different types of shapes of pelvis. They have what's called gynoid. About 50% of women have this type pelvis. And if you look at table 26 or 27-2, there's a good table here talking about that. The gynocoid can be vaginal birth. Another shape is heart-shaped, which is the android. which about 23% of women have. This is good for C-section. If vaginally, it's very difficult, may have to use forceps. The anthropoid, about 24% of women have this. It's kind of oval shaped, and this can be delivered vaginally with forceps or spontaneous, or two different occiput positions that may work for the birth. The platypeloid is kind of flat. Only 3% of women have those, and that's more of a vaginal spontaneous birth there. So some different types and shapes of pelvises. All right, next up, passageway. Passageway talks about the soft tissue. We have the uterine tissues. The walls of the fundus become thick and help provide force during the contractions. Cervical tissues, as the contractions provide pressure, the fetus will efface and the cervix will dilate. The vagina, as the pregnancy progresses, there is an increased supply of blood to the vagina, also an increased thick mucosa of the vagina, which helps in the sliding of the baby as the baby is born. The vagina will also hypertrophy the smooth muscles, which allows more room for stretching and dilation so that the baby can come out naturally. The perineum will stretch and get very thin. The pressure from the birth may dilate and bulge. The anus at this point. Sometimes mothers may have a bowel movement as pressure on the perineum with the birth of the child occurs. The physicians will very quickly clean up that stool so that mom is not embarrassed, and mom hopefully will not even remember that. There is not a big deal made about the incident if the mother does have a bowel movement, because like I said, it's very common, and I think we have some pictures later on that kind of show that enlarged anus, so it's very understandable that mom might lose control of her bowels. Next up, the softening of the cervix allows dilation and effacement for the birth. The medication is applied. The Cytotec, if you will, this is on page 812. (812) to 814, a lot of the medications for a normal birth. The Cytotec is on page 612, helps induce labor. It's also used for to help decrease stomach acid. If it's given for that reason, the physician has to make sure that the mother is not pregnant at the time. The Cytotec and the Cervidil are both directly applied to the cervix, and if they do apply this to the cervix to further ripen the cervix in preparation for the birth, the mother cannot get out of bed, because that baby could be be, birthed and, land in the floor. So we definitely do not let the mother get up after this. All right, passenger, of course, that's our fetus. The fetal skull is usually the largest part of the baby. They will usually do an ultrasound again to determine if the head, and they can measure the size of the head to make sure it will fit through mom's pelvic bones. The fetal attitude is described as should be the best attitude is with flexion, with the chin, the baby's chin on the baby's sternum, and the baby's arms are crossed over the chest area. This is the best optimal position for the birth. The fetal position in relationship to the sides of the mother's pelvis. The baby may be front, back, or right side or left side in relation to the mom's pelvis. Okay, this is what if you're looking down at the top of the baby's head, we have these suture lines and your fontanelles. That anterior fontanelle, of course, is larger than the posterior. And with looking at this, and the reason these suture lines and fontanelles are not closed is this helps the baby's head with the pressure of coming down the birth canal to be able to glide. These bones will sometimes get pressed over. They may overlap trying to get out of the birth canal, and that's why a baby's head is not one solid bone at that time. It's just so we can get the baby, can get through the birth canal and be born naturally. On this picture, you need to know which one is the anterior fontanelle, which one is the posterior fontanelle, and that the others are called sutures. And as these kind of sometimes glide over each other, that's called molding as it's coming down the birth canal. Now, some babies may be born with what looks like kind of a cone-shaped head. And they look like that because they have been in the birth canal too long, and so their head kind of forms into the shape of that birth canal. And like I said, it will be kind of a cone shaped. But there again, in a few days, their head will go back to normal. But it is something that you will see from time to time, that cone shaped head. So don't make a big deal of it. Please don't, say anything negative in the birthing room. If you're in that birthing room, it's all positives, okay? And keep mindful of how your face looks, your expressions when you're in that birthing area. I know we're shocked and happy, but sometimes things may not be real pleasant and sweet, and so but we still need to kind of keep our game face on, and our game face again, smiles, positive expressions, coaching that mom, you can do this, irregardless of what else may be going on. So let's see, the passenger, again, the baby, we have the fetal lie, which is how the baby's spine lines up with the mother's spine. If the baby's spine and the mother's spine are parallel to each other, that is considered longitudinal. Longitudinal is about 99% of deliveries. Like I said, again, their spinal columns are basically side by side, running in the same, line. The presentation is what part of the baby is in the pelvis or is lying over that birth canal. So this could be a couple of different things. We really want it to be the kind of the head. If the baby's chin is tucked onto its sternum, the kind of the top of the baby's head will be what you see, the top of the head. That's really what you want to be seeing. But sometimes we may see part of the face. They sometimes call this the brow presentation. Another thing that could be a butt could be the presentation, or a shoulder. So sometimes physicians will try to turn these babies. They will put a sterile glove in and go in, put their hand in and try to manipulate and turn that baby so the baby's head is coming out, not their butt or their shoulder. Again, and of course, as you may realize, the breech is the most difficult. Baby, kind of that butt showing or a leg coming out. Again, breech is the most difficult. These are oftentimes delivered by C-section. About 96% of births are with the head presentation like we want. 3% of births can be breech with the buttock coming out, and about 1% will present with a shoulder, a hand, or an elbow coming out. We had last time the group that went to OB said that they had a baby's hand slip out. You could see the hand, and the baby was kind of waving its little hand. So you just never know. I believe the physician for that one got in there and turned the baby so that it was coming out head first. So a little confusion there, but it all worked out in the end. Okay, looking at this picture, this is on page 804 in the orange book. Should be about that same in the green book. Have a couple of different presentations here with the baby. You have the occiput at the top there, a right and a left occiput. And then the bottom two are also an occiput as well. On this one, the best one of these is the LOA, which is in the bottom right-hand corner, left occiput anterior. That is the best position. The second best position is the ROA, right occiput anterior is the second best position. This position has the baby's head flexed, chin to chest, arms are crossed, legs are drawn up. The fetal skull can easily pass through if mom's pelvis is open enough and she is dilated to a 10. This position also prevents the umbilical cord from slipping out. If the baby's head is not engaged in the pelvis, the umbilical cord can slip out. I'll try to remember, we'll talk about that next Friday. But if that umbilical cord slips out, there is a dangerous chance that the baby will roll over on that umbilical cord and compress the umbilical cord to the point that it will cut off the oxygen to the baby. So again, once that baby gets its head in the birthing canal, ready to it will block off that potential for that umbilical cord to what they call prolapse. And again, it will kind of slip out there. So we don't want that to happen because it will cut off the blood flow in the umbilical cord, which will cut off the oxygen to the baby. You can kind of compare that to somebody putting a pillow over the baby's face, which we definitely do not want to do. If this were to happen, this is if the umbilical cord is coming out of the cervix, out, in the open, you can see it. This is a medical emergency. Okay, what they have to do when this happens, one of the nurses will have to put on sterile gloves and put her hand inside the cervix and raise up the baby, get that head or whatever that presenting part is off of that umbilical cord so the umbilical cord can work as it should. They will be getting her to OR ASAP with, again, they'll be running down the hall with that pregnant mother and someone's hand on that baby's head, so we're not compressing that umbilical cord, because the longer that baby is without oxygen, the increased chance of brain tissue death. So again, medical emergency, quick, we've got to get that baby out. If the blood flow is occluded for 5 minutes or longer, nervous system damage and death to the fetus is highly probable. So again, sterile hand and hold pressure off that umbilical cord and to get them to the OR quick. All right, our passenger, again, that fetus, when mothers come to labor and delivery, the first thing they do is they hook them up on a monitor. The monitor will monitor the mother's contractions, but it also monitors the baby's heart rate. That really helps us understand how that baby's doing inside the mother. And this talks about deceleration. Decels are when the fetal heart rate drops below the baseline. When we first hook them up on the monitor, we should usually get us a good baseline, the baby's heart rate. So again, we know the heart rate can run anywhere from 110 to 160. So if we're having, the baby's been continuously running 140 and all of a sudden that 140 goes down below 140, they're going to keep monitoring it, but those are decels. And so if it continues to decelerate, we've got a potential problem. There are two different types of decels. One of them are early decels. And an early decel is a decrease in the fetal heart rate at the onset of the uterine contraction. So this is just the beginning of the uterine contraction. The heart rate drops below normal. And the second one is called late decels, late decelerations. And this happens, the fetal heart rate drops at or after the peak of the uterine contraction. Now again, let me say this again. Late decels are when the fetal heart rate drops at or after the peak of the uterine contraction. And this is an emergency. This baby will be having hypoxia. He or she will not be able to breathe as well. And like I just told you, that baby cannot do without oxygen because they will have CNS damage and potential death. So babies that are having late decels, we've got to get that baby out quick, whether it be racing again to the OR and getting them out that way, or getting them forceps and quickly pulling them out. So late decels are very bad for the baby. So we do not want those, and we're always monitoring their fetal heart rate. These monitors are similar to the heart monitors that our patients in the hospital will be wearing. I mean, in that they are monitoring the heart rate. And so what happens, these monitors can sense problems, and they'll sound an alarm, okay? And I think I've already told you that at the nurse's station, there's a set of monitors that the techs, the HUC, and any nurse that's at the monitor can watch these monitors and see how the mother is doing. Plus, if there is a deviation from the normal, whether it be early decels, late decels, those monitors are going to sound, and it's going to draw your attention to look at the monitor and, hey, we got a problem in this room. We got to get down there. So, again, late decels, not good. Fetal hypoxia, we've got to get this baby out. All right, so this is kind of what the heart monitor looks like. They'll have, if you'll notice, the two different straps. One of them is for the uterine contractions, and the second strap is for the baby's heart rate. They will typically find the baby's heart rate and get that monitor right over the baby's heart rate so that they can have a clear picture of the heart rate. And also, again, the other one monitors the mom's contractions. So here we go. This is what the monitor basically shows us. It will show us the contraction. And so with the uterine contraction on the TOCO monitor, you have, let's look at what we're seeing here. If you look down at the very bottom, it talks about the frequency, how frequent, and that's from the beginning of one contraction to the end of to the beginning of the second contraction. That's how frequently they're coming. So in this picture here, those contractions are coming 2 minutes apart. And so, because if you look again above the word frequency at the bottom, it has 1 minute, then 2 minutes. That tells you how frequently the contractions are coming. So this monitor says those contractions are coming every 2 minutes, which is pretty close, close together. This baby's probably going to be born in the next 15, 20 minutes, if that, maybe even sooner. So the duration is how hard the contraction is. I'm sorry. Duration is the time between the beginning and the end of one contraction. And the intensity is how hard that contraction is. The increment is the contraction up until the acme, and the acme is the peak. So at the peak of the contraction will start going down, and that is your decrement. So increment up, acme peak, decrement down. And then we have the interval between the interval is the time between the end of one contraction and the beginning. But again, like I said, your minutes, how many minutes apart they are in this setup here, the frequency, and that's going to be a 2 minute. Frequency is the time from the beginning of one contraction to the beginning of the next contraction. Now, if a contraction is last longer than 90 seconds, and that's we're talking about the increment of the contraction lasting longer than 90 seconds, we've got a problem. The baby has a problem. The baby cannot catch up, cannot catch its breath. So if the contractions are lasting longer than greater than 90 seconds, then, and in this picture here, that's going to be your duration, the length of the contraction. So this one's showing at 60 seconds, which is good. But if that contraction was lasting longer than 90 seconds, the baby doesn't have time to recover. So the baby is going to lose oxygen. It's like there's a pillow being placed on the baby. So if this mother is getting Pitocin, IV Pitocin, the nurse will turn off that Pitocin and turn the mother on her left side, and she will put some oxygen on that mother so that the mother can recover, the baby can get more oxygen as well. Okay? And again, that interval, that time between the end of one contraction to the beginning of the next needs to be about 60 seconds. Anything greater than 90 is detrimental to the baby. So we've got to get that baby some time to recover. All right. The fetus, fetal distress, fetal hypoxia, fetal meconium, and a prolapsed cord are very detrimental to the baby. Fetal distress happens when that fetal heart rate is dropping way below its normal, or the contractions are greater than 90 seconds, and so the baby doesn't have time to recover from the contraction. So all this is very bad for the baby. So because if the baby can't recover from the contraction, or the contractions are lasting longer than, and they can tell if the baby's able to recover by watching that heart rate. If the baby doesn't have enough time, the baby can't breathe, the hypoxia again can lead to brain damage and death for the baby. Also, if the baby's in distress, it may pass its stool. And the first stool a baby passes is called meconium. And we prefer that meconium to be passed after the baby is born and it passes into a diaper. So, but sometimes, like I said, under stress, the fetus may have its bowel movement in the uterus. If that happens, we worry about infection. So again, we've got to get that baby out. Also, when they break the water sac, if there's any meconium in there, that baby's been under some stress. That baby may have been in there too long and it's past stool. So we have to worry about perchance of infection. And another fetal distress is that prolapsed cord. Again, that cord comes out out of the mother's body and it's visible, or when the nurse checks the mother, she feels that cord instead of the baby's head. That's a danger sign. We've got to get that baby out of the mother as soon as we can. Like I said, it's a medical emergency. The baby can't breathe. So, medical emergency. And also remember, when you are in labor and delivery, that the RN can check the mother. She can check the size of the cervix and the station, but you cannot. Do not put your hand inside a woman. That is not an LPN function. It is against boards, and you cannot do it. Okay, so don't. It'd be fun to feel, I'm sure, but you go on and get your RN, and then you can put your hand in there and feel for the baby's head. All right. The placenta is also a passenger. After the birth of the baby, the physician will deliver the placenta. We have, let's see, a figure, let's see, on page 805 in the orange book, and it should be similar to in the green book, figure 26, or if your book is 27-8. It shows you the third stage of labor, the delivery of the placenta. We have the shiny Schultz and the dirty Duncan. The shiny Schultz is in relation to what is around the baby, and the dirty Duncan is the what is up against the mother. Okay. Shiny Schultz should be on the fetus side, dirty Duncan on the mother's side. Let's see. After the placenta has been delivered, the nurse's job will be to palpate the fundus, to encourage the fundus to begin contracting back to its normal size. So as after the birth of the baby and the placenta, we want that fundus to start shrinking back down to size. As it shrinks, the blood flow slows down, and that's a good thing. We don't want mama to bleed out or bleed to death. So again, we do some palpating of the fundus and rub it, palpate it until it's firm. And once that fundus is firm, we don't keep massaging, okay? We just massage until it's firm, so that it will shrink back and slow the blood flow down. Now, if we kept massaging it, the uterus would be too relaxed, and if it's too relaxed, it will not clamp down and shrink. It will remain the same size and continue to bleed heavily. And again, too much bleeding can be bad on the mother. She could die from this. So again, we've got to do our job. You will hopefully be able to massage the mother's abdomen, her pelvis area, on the top of her skin, and help massage that fundus. So again, we want that to start getting smaller and smaller and smaller, so the blood flow will stop. Okay, so rupture of the membranes. SROM, spontaneous rupture membranes. This means that the mother's membranes have ruptured on their own. And so we will, again, make sure that we're paying attention to the timing of the rupture of membranes. Record the amount, and if you work in labor and delivery, you will get accustomed to making a good estimated amount. Again, on page 819 in the orange book, box 264 in the green book, it should be about 819, but it would be table 27-4. Again, those characteristics of the amniotic fluid. AROM is abrupt rupture of membranes. There is a picture on page 830 in the orange book. It's figure 2626. So in the green book, it should be about that same page too, 830. And it would be figure 2726. There's a couple of ways that they can do artificial rupture membranes. That first picture is an amniotic hook. Has a little pointy thing on the end of it, so it will pop the membrane, rupture the membranes, or the finger or finger hook is picture B. Again, that would be a way to rupture membranes. We check the ruptured membranes with nitrazine paper. Again, that nitrazine paper turns blue, and so it's very acidic, and that's what we want to see. If it does not turn blue, then it is probably the mother has accidentally peed on herself just a little bit. And that is common, again, because the baby is down in the birth canal and putting pressure on the mother's bladder. All right, so nursing considerations with the rupture of membranes. Again, record the time because we have about 24 hours to get this baby birthed. Estimate of the amount of fluid, the color of the fluid. The fluid should be pale or straw colored. It may have a little bit of vernix, laguna in their scalp hair. The fluid should be watery, and it should not be a strong odor. If there is a strong odor, that could be infection. It could also be a stool. Sometimes, again, with fetal distress, they will have a bowel movement in the uterus, and so there could be some meconium there. And also, we want to record how much, how the membranes, were they ruptured on their own, or were they artificially ruptured? Again, on the amount, normal is about 400. Anything greater, let's see, deviation from normal, anything greater than 2,000 we worry about. That's too much fluid. Hydromenous, excessive amount of fluid. It's, if you look at your table, relates to congenital abnormalities, increased risk of gestational diabetes, could be fluid trapped in the fetus. Also, anything low amount of amniotic fluid, less than 300 mils, can it's associated with an incomplete or absent kidney, maybe an obstruction of the urethra. Fetus cannot secrete or excrete its urine. So some potential problems there. Again, artificial rupture membranes. Checking the color, the clarity, odor, amount. Looking for that prolapse cord, and also that fetal heart rate. It's very important. We also don't want to see any blood in that. If it's got been bleeding, could be premature separation of the placenta. That does and can happen. That's called abruptoplacenta. So we don't want that to happen as well. Pitocin administration. Again, Pitocin helps speed up the labor. Of course, we don't want it going too fast, because if the labor goes too fast, then the baby cannot recover between contractions and can become hypoxic. So we want to be carefully monitoring. The Pitocin kind of has a diuretic effect. It can only be administered IV. We have some adverse side effects. Uterine hyperstimulation. Again, the contractions are coming too hard, too fast, too close. dangerous for the baby. It will cause reduced fetal oxygenation. It can also cause the uterine to rupture. And it can cause a precipitous rapid labor. Precipitous rapid labor is usually considered if the labor has been 3 hours or less. We could have some cervical lacerations, meaning we could have some cervical tearing at this point. It can cause water intoxication, and that's due to acute hyponatremia. Causes to the mother, causes confusion, vomiting, coma, can cause some cerebral edema or death, and this can happen with continuous infusion of the Pitocin. So again, we really have to monitor these patients on Pitocin. And also remember too, it's not just the mom, we've got a baby too. So one physical person in front of you, but 2 potential clients or patients there. The powers in labor and delivery are those contractions. Early labor, we have some, let's see. Primarily, we have the contractions will have that will thicken up the uterine muscles. There'll be periods of rest in between. During the labor, early labor can be the contractions are 15 to 30 minutes apart, and the contractions last about 20 to 35 seconds. So that's early labor. The later part of the labor or the contractions can be 2 to 3 minutes apart and last 60 to 80 seconds. So again, we want to be sure we're paying attention to that fetal monitor and the monitor on the mother. With the labor, the mother's, the baby will efface and drop down into the pelvic cavity. The cervix will dilate, and that dilating of the cervix will cause the baby's head to go lower and lower till it's to the point of you can see the baby's head through the mother's open legs. The effacement is the percentage of the baby's head that's coming out. There is a picture of effacement on page 806 in the orange book. It should be on 806 in the green. First picture is the baby at 0%. Second picture, about 50% of the cervix is dilated. And the last picture is the cervix is dilated 100%. That baby's pretty much ready to be born at any moment. And then dilation occurs in what's called centimeters. So if you kind of look at this effacement picture on 806, dilation in that first picture would be 0. The second picture at 50% would be about 5 centimeters, and the 100% effacement would be comparable to the full 10 centimeters dilated, and that baby is ready to come. When we get to the 100% effacement and 10 centimeters, we can start pushing the baby. The mother can be assisted and helped pushing the baby out. Okay. Uterine contractions, we've talked about that a little bit when we were looking at that graph of the intensity, frequency, and intervals. duration, time between beginning and end of one contraction. Greater than 90 seconds is a problem. I would be worried if I saw it greater than probably 75. So again, something to monitor. If it's a little high, keep watching. If the seconds start ticking higher, then make sure that we're alerting that registered nurse so we can get in there and do something about that. Intensity is the strength of contractions. Frequency, time from the beginning of one contraction to the beginning of the other, and those are in minutes. And the interval between the end of one contraction and the beginning of the next should be at least 60 seconds. That gives the baby time to rest a little bit, catch their breath. If that interval is not 60 seconds, then the baby has not got a good recovery time, and that will start having what's called those late decels, and that can be very dangerous to the baby. So very, very definitely something we've got to keep an eye on. During the first and second stages of labor, the contractions increase in intensity, the uterine pressure increases. It helps push that fetus down into the cervix. At this point, sometimes they will have pain meds. They can get an epidural. Epidurals, though, if they get the epidural too soon, the epidural can cause contractions to slow down. So, secondary powers, the presenting part comes, starts showing that cervix is going from 0 to 10. And so at that 10, we're going to have mom start pushing. She's going to feel that need to push. And again, like I told you before, mom could also in this time frame have a bowel movement. Physicians will typically cover it, clean it up, because we don't want to embarrass mom. So keep that in mind when you're in labor and delivery. That is a potential complication of the birthing process. Position of the mother. There's some varied positions on Orange Book, page 807, for the mother to be in labor. Pretty much what's comfortable for her is what they go by. But now if as long as and she can move about as much as she wants unless they have applied the Cervidil to the uterus or the prostaglandins, the Cytotec or the Cervidil. At that point, if they've applied either one, then the mom can't get up out of the bed. So we've got to make sure we're watching her as well. Kind of that upright position is preferred for the mom. Upright position helps decrease the pressure of the baby being on the vena cava. So again, we don't want to have any pressure on that inferior vena cava or the ascending vena cava or the descending aorta. So that will cause fetal hypoxia. Again, any pressure on the ascending vena cava or descending aorta can cause pressure if the baby's laying down or the mother's laying flat. It can cause pressure on those. And of course, when their pressure is applied, they will compress, and the baby will become hypoxic. So very much so dangerous complication. And we'll be watching those heart monitors as well, the baby's heart monitor. Okay, the mother's psyche. This is how the mother feels about the birth. If she is anxious, fearful, she's not going to deal well with it. Again, we can help with these anxieties and fears, with education, and the nurse being calm and talking calmly to the mother and educating her, and also helping dad, instructing dad ways to help the mother. And you can see that in some of these pictures here on page 807. The spouse or significant other comforting the mother, kind of massaging her, being supportive, will help with the anxiety and fear potentially. And also, again, and the longer the labor progresses and lasts, the increased possibility of fatigue for mother and just feeling worn out, and that is to be expected. But we need to really help her with that, and also her ability to cope with pain. Some people do well with pain, other people do not. So that is something to take into consideration. Not everybody handles pain the same way. And also, some people's threshold for pain, meaning they can stand a lot of pain before they complain, or maybe they can't stand a lot of pain. Maybe they will start, expressing their pain at an earlier point during the process. So again, we've got to take care of mom's physical body as well as her psychological body. And those nurses are very well trained to do with that. So be especially paying attention to what's going on around you during these labors and deliveries. See how the nurses take care of the moms and the dads or significant others and siblings, but also watch how the physician treats the family unit as well. Again, it's supposed to be very caring, loving, supportive time for everyone. All right, question 1. Let you look at that. A patient is hoping to be admitted to the hospital to give birth. Which symptom would indicate the woman is truly ready to give birth? Let you look at that in a minute. All right. So we're looking at the first one, the first answer, contractions don't follow any sort of pattern. Well, that's a false labor. So she's not in true labor with number 1. Number 2, contractions are stronger when she's laying down. Well, that would not be true. Contractions typically get stronger as you stand up and walk around. Number 3, contractions cannot be stopped with relaxation techniques, and that's going to be your correct answer. Irregardless of trying to relax, the contractions are, becoming stronger and shorter intervals. Contractions are mostly in the fundus, and that's not true. The contractions generally start in the back. And you may see some deviations. Again, they'll be on monitors as much as possible so they can see the progress of the labor. Question 2, the most prominent in pelvic type. If you look back, think back, you will see that the correct answer is number 1. Gynecoid is the most popular, about 50%. All right, what is the name of the relationship of the fetal parts to one another? I'll let you look at that a minute. Okay, that is your fetal attitude. That is the relationship of the fetal parts to one another. It's the fetal attitude. All right, the stages of labor. we have the first stage of labor is the dilation stage. And the dilation stage has 3 parts. Early latent phase is 0 centimeters to 3 centimeters. The mid or active phase is 4 centimeters to 7 centimeters. The transitional phase is 8 centimeters to 10 centimeters, and mothers can, when they get to that transitional phase, labor can sometimes be very quickly, birth can be very, imminent. So pay attention when you're in that labor and delivery area to when, the nurses call the physician and make them aware of, the state, the cervical dilation, very important. Make sure as you're thinking and we're talking about labor and delivery that you write down questions to ask. And some of you will be going to labor and delivery very soon, and so you'll want to ask questions. Ask a lot of questions, but write them down so you remember. And after you've been in labor and delivery the first time, if there's some questions you wish you'd ask, write them down. Ask them the next time. So, but your questions are very important, and labor and delivery is a wonderful time, a wonderful place to be asking questions and learning how to take care of mother and child. All right, the second stage of labor is the delivery. Delivery can, again, like I said, can be very quick, but typically most deliveries take 30 minutes to 2 hours. Again, when mom gets to be at a 10, they will start encouraging her to push. She may feel the need to push at this time. Something that the physicians may have to do at this point, if the baby's head is a little bit big, or maybe there's just still not quite enough room, they may do what's called an episiotomy to prevent tearing of the perineum. That is done in the second stage. There's a picture of this on page 811 in the orange book. It's figure 2616, or in the green book it should be 2716. And it shows a couple of different types of episiotomies. Again, this will help prevent tearing of the perineum. Some physicians still do a lot of these. Some have backed away from it. It just depends on the physician. If the physician chooses to do this, the episiotomy is done with a scalpel, so it gives a clean cut. It will be sewn back together, and potentially it can heal better. If it's sewn back together, it'll heal faster and better as opposed to a tear. Again, they for some physicians use these quite frequently, and some do prefer not to. Not sure why, but I did have other students say that their physician did not do an episiotomy and it did cause a rip. So, but there are complications with either one. You have, like I said, with tearing and or with an episiotomy, there's a complication, chance for infection. There's a chance for blood loss. There is, of course, there's chance for pain with either one. Okay, let's see. If they do an episiotomy, again, that's done in that second stage. The next stage, as the baby's head comes out. So if you kind of look at that birthing pictures on 809, the baby's head in page 809, figure 2613, and it should be on 809 in the green book, figure 2713. The baby's head is coming out of the vagina. and you can see its head. The physician tries to manipulate the baby's head a little bit in D. E, they're turning just a little bit. They have to check. They take their finger and check under the baby's neck to see if the cord is wrapped around the baby's neck. If the cord is wrapped around the baby's neck, that is called a nuchal cord, spelled Nuchal. So the physician, birthing the coach will pull that out from around the baby's neck because we don't want to strangle the baby. The next step is, if you'll turn the page to the next page, you'll see there the baby's still in the mother's, partially in the mother's body, but they are suctioning the baby's mouth first, and then they suction the nose. They suction the mouth first. It's not as potentially dirty as the nose. And then they will, as the baby comes out, oftentimes they will lay it on the mother for some bonding. Then they will clamp the umbilical cord in two places, and they will cut the umbilical cord between the two clamps. So they clamp it off to decrease blood from spurting from either the umbilical cord from the baby or the spurting from the placental side. So again, two clamps, and they will cut right in the middle of those two clamps. The nurse will look at that umbilical cord, and she is looking for 2 A's and 1 V. Again, she's looking for 2 arteries and 1 vein at that point. All right, the third stage of delivery is going to be the delivery of the placenta. Delivery of the placenta can take anywhere from 5 to 20 minutes. During this time frame, the physician will also, if he's done an episiotomy, he will suture it back together, repair it. Physician will also estimate the loss of blood, and normally a mother will lose between 200 and 300 milliliters of blood. If there is more than 500 milliliters of blood lost, that's considered excessive. They'll probably, depending on what her H&H was before the birth of the baby, but they will definitely be looking at that. At this time, oxytocin may be used if it wasn't before the birth to augment the birth. Oxytocin may be given in this stage 3 to help stimulate uterine contractions, which will essentially help shrink that uterus back down to size. And again, we want to, nurses will be doing a fundal massage on the mother's abdomen, the abdominal area there, to help massage that fundus back, and you'll only massage until firm, and then you'll stop. But again, the oxytocin can be used as well to help those contractions, to help shrink that uterus back down to its normal size. And with the shrinking of the uterus, it will decrease the blood loss, and that's what we want. Okay? The fourth stage of the labor and delivery is monitoring mom for the next 2 to 4 hours. The OB nurse will be monitoring mom. The nursery will be monitoring the newborn. The nursery will have some tests they run on the baby, and length and weight, and probably go ahead and give them their medication that they give them. They give them some gentamicin drops in the eyes to prevent infection. They will also do a heel stick, check blood type, and maybe go ahead and give the vitamin K. That definitely do these very shortly after birth. Stage 4, again, the nurse is watching the mother's vital signs. She's checking the fundus and massaging the fundus. She's also checking the vaginal discharge, drainage frequently because we don't want to see an increased gush of blood or anything. Doing the fundal massage and checking those perineal tissues, especially if she's had a tear or an episiotomy. So a lot going on in this time frame as well. All right, we've got pictures of the cervical dilation, and again, this goes in centimeters. This is, of course, a smaller version. If you had a ruler in front of you to look, this actually probably the one that says 10 centimeters may be more like closer to 2. So again, it's approximate, and they do go and you put their hand in to check the dilation and what's the presenting part. So they try not to go in there and check too frequently because I don't want to chance the risk of infection. But again, when the nurse is checking the dilation, she's got sterile gloves on. And remember, LPN students or LPN employees cannot put their hand in the vagina, okay? It's not a place for you, okay? You want to do that, you got to go get your RN. All right, cervical effacement. As you can see in this picture, on the left, there is no effacement. The mucus plug, as you can see, that is oftentimes will come out either with the ruptured membranes or shortly before the membranes rupture. And as you can compare to the baby's head on the right, right and left on the cervix on the left is very thin, meaning its diameter is not very wide, and it is long. But as that baby's head starts coming down into the birth canal, that cervix is very narrow. It's not long and thin, it's short and wide. So that gives room for the baby's head to come through. And you see the changes in the vagina. It's getting wider as well for that baby's head to potentially come through the birth canal. So the baby on the picture on the left is not effaced. It has potentially dropped and it's getting ready, and the babies will do that in the last few days, if not a week or so before birth. All right, so we as nurses can do something called Leopold maneuvers to try to determine how the baby is lying in the mom's abdomen. This is again helps to determine whether the head, the face, whether the presenting part is the head, the face, if the baby's coming breech or breech buttocks, or if the baby's coming shoulder. This is done on top of the woman's abdomen. Some nurses may still do this. Kind of watch and see what your nurse does in labor and delivery. I've had several students in the past say they never saw this being done. Again, I think with the use of the ultrasound, that has kind of maybe decreased the chances of them having to use Leopold maneuvers. In the field, an EMS person you may see them doing it, if somebody's doing an at-home birth, trying to, without the use of an ultrasound or having an ultrasound available, being able to position your hands to try to feel and determine what that presenting part would probably be, good to do. So. All right, the fetal lie. The position is in relation to the mother's spinal cord. As you can see in the first picture A, the baby is parallel. The baby's spinal column is parallel to the mother's. And in picture B, the baby's spinal cord is transverse. Unless the baby can be turned, the baby in the B position, if the baby, like I said, sometimes physicians will try to turn them laying sideways. You can't deliver like this at all, so the baby would have to be turned, or they may have to go ahead and schedule and get them down to the OR for a C-section because you can't get the baby out. There's not room to get it out sideways in the transverse. So not a good position, okay? All right, so we have a cephalic presentation. That's when the head enters the pelvis first. That's what we want. Vertex is the occiput of the baby's head is in the birth canal, whereas if you see the face, that's called mentum. The baby's breech, you may see a buttock, you may see a foot or a leg. And then there is the shoulder presentation. Let's see, page 804 in the orange book should be similar in the green book as well. Show at the very top of the page 804, figure 26-6, or it could be should be 27-6 in the green book. But there again, any of these positions, if the physician may try to turn them, otherwise they may just say, okay, we're just going to do a C-section. So maybe easier on everybody all the way around. All right, fetal presentation. Of course, this is with the head coming down. We have the A baby is what's called a brow presentation. And you can, like I said, we talked earlier about the baby's chin should be pressing on its sternum and its arms crossed. Well, the A baby has his arms crossed, but his chin is not tucked to its sternum. So this baby is presenting what's called brow first. You can kind of see the eyebrows coming out instead of the top of the occiput of the head. So this one, A baby, is definitely a brow presentation. The baby in figure B, and the pictures at the bottom kind of show you if you were standing there looking at between the mother's legs, that's what you would see. So in the B one, that's a face presentation, and again, it's called face presentation because it is the baby's face. You can see the baby's face, and that's again, a physician may try to turn this baby so that it comes out with its chin being tucked. Face presentation can also damage the baby's face, so it's not a position that we would really want mom to be in for the birth. All right, fetal position, fetal assessment, the position in relationship to the landmarks in the 4 quadrants of the mother's quadrant. We think about most common is the LOA, and the LOA is left occiput. There's a picture of this on page 803 again. LOA is the bottom right-hand side because it's the left side of the mother. Left presentation is most common, and it is the easiest for the mother. The second most common is the ROA, and that is the second most common position. If the baby is in the position of LOP, the mother will have a lot of back pain. So those top two, ROP or LOP, these mothers will complain a lot of back pain with the baby in that position. So. All right, these are a different picture of the positioning. What I really want you to remember about this, you don't have to memorize it, but what you need to know is that LOA is the best position, and then ROA is the second best, okay? So keep that in mind. All right, the engagement. When the widest part of the baby's head is lined up at those ischial spines, and you'll see on this picture those ischial spines kind of glow a little bit baby blue, and those are those ischial spines. There's a good picture on page 808 in the orange book, figure 2612. It should be on the same page in the green book, and it would be figure 2712. But as if you look at the figure in the textbook, the babies, as the baby's coming down the birth canal, we have a -5 in the book, -4, -3. So the baby's head should be steadily coming down. When it gets to the 0, that is with the ischial spines. At that point, we should be dilated to a 10. The baby's head's engaged, and we're ready to start pushing. We're ready to deliver this baby. So that's where we want to be. Here's a picture with that baby's head. Now in this position, when it goes to 0, again, we start pushing, and that baby's head will start becoming a positive number. That station will be +1, +2, +3, +4, and so forth until we get that baby out. Second stage. Again, we're looking back at that second stage of labor, and we're starting that second stage. Once that baby's head is at 0, we're at the end, and we're fully dilated. We start the second stage of labor. Again, that lasts 30 minutes to 2 hours. Mom will feel the need to push. If the physician feels the need to do an episiotomy at this point, that's when they'll do it. Again, some physicians don't do it. They let the mother tear. Again, not sure as to why. But either way, if it's a tear or it's a cut incision, we do have the chance of complications of infection, increased blood loss, and perineal pain. So again, some complications either way. All right, next step, we push. Yay! Time to get this baby out of here. Woohoo! When the mom's fully dilated and the baby's effaced, and we're in that 0 position, now's the time to push. Sometimes moms report feeling like they may have a bowel movement, and that's because the baby's head is putting pressure on the internal organs. And if the mother has not already been told she's bed confined, then she will be at this point. We don't get up at all when that baby has gotten into that 0 position. So we will, and we definitely, like I said, we don't let them get up and walk around because the baby could just slide right out because it's all slippery. So we definitely don't want the mom getting up out of bed. If she got up to try to go to the toilet, she could have the baby in the toilet. So, and also with the need to feel like they're going to have a bowel movement, they may have a stool, and again, the physician will stop and clean the babies, to clean the mother up. Okay, this is where I'm going to stop. I'm so excited. We're about to have a baby. So, but thank you for listening. I hope I didn't bore you to tears. You should be able to keep, re-listening to this if you need to. Write down any questions that you have concerning the PowerPoint and be ready to ask them next week. I miss y'all, and I'm looking forward to seeing you back next week, okay? Thanks a lot.